Hello friends. Now today we'll be start a new system and revision of the USMLE Step 1 first step renal system. So we'll divide this revision in 4-5 parts. That we'll conclude it first part as anatomy, then second and third as physiology, then pathology, and finally pharmacology. This will be the whole revision of the system, and one system will have 5 or 6 video, and accordingly we'll deal with that. Okay, so let's begin it. Renal system, it is one of the important system and a favorite of mine. Before starting it, today we will be discussing about the anatomy of renal system. So normally a kidney lies, when we compare in our body, then it lies from T12 to L3. This is the location where it lies in the lumbar region. You know there are two mid-clavicular line and one transpyloric plane and transtubercular plane. This divide into our abdomen into 9 regions. That is hypochondric, lumbar and iliac region, and in mid is epigastric, umbilical and hypogastric region. So kidney lies in the lumbar region, and the area overlying the kidney is known as the loin. So now, to understand that, we knew that kidney lies in the lumbar region. If we compare with the transpyloric plane, then the hilus of the right kidney and the hilus of the left kidney. Actually, right kidney is lower, left kidney is upper. So left kidney lower zone and lower pole, and right kidney upper hilus pole lies at the L1 vertebra, that is on the transpyloric plane. Okay, so when we compare, if you go from the kidney from the back, there will be actually skin. There will be skin, then there will be a superficial fossa, the skin, superficial fossa, then there will be a deep fossa. This deep fossa is actually posterior layer of posterior renal fossa. Okay, then there will be the middle layer, and there will be the anterior layer of renal fossa. So in between the posterior and middle there is one muscle, that is erectospinae or spinous erectospinae. Then in between these two, middle and anterior, there is quadratus lumborum. Then there is the anterior. So skin, superficial fossa, deep fossa, that is posterior layer. Then the middle layer, and in between the posterior layer and the middle there is one muscle, that is erectospinae muscle. And between the middle layer and the anterior layer, there is another muscle, that is quadratus lumborum. Okay. Then we come the anterior layer. After that is paranephric fat. Okay, then there is a renal capsule, which is a false renal capsule. Then there is perinephric. There was paranephric fat, perinephric fat. Then there is a true capsule, and finally the kidney. Sometimes you may ask about the kidney from back and about the structure. They may ask. Okay, that will be the one other point. Then when you know about the location, that where it is located in our body. Okay, now we'll start with the embryology. Embryology begins from it usually comes from the intermediate mesoderm, from where there is a formation of this pronephron, mesonephron and metanephron come from the nephrogenic cords, and that comes from urogenital rings, and that urogenital has come from intermediate mesoderm. So intermediate mesoderm, from there urogenital rings, from urogenital rings nephrogenic cord. From nephrogenic cord, the cephalic portion develop the pronephrons. Pronephrons usually last for 4 weeks, and it degenerates. It usually doesn't have any function. But then mesonephron develops at 4 weeks, and this mesonephron comes from this nephrogenic cord middle portion, and that is actually a interim kidney. In the first trimester of life, this mesonephric part is forming the kidney, functioning as a kidney in the first trimester of our life. Okay, and this actually gives has two major functions. Distal part is responsible for the formation of caudally. Normally, there is a formation of this ureteric bud Number one thing, and second one is the formation of male genital system, that take parts in the formation of male genital system. Okay, so it's formed in the male genital system and this ureteric bud. Okay, so let's focus on here. This ureteric bud, this ureteric bud, when it combined with the metanephrons, it is the metanephron mesenchyma, that is metanephric blastema. When this ureteric bud and this metanephric mesenchyma, they correlates, when they interact in a proper fashion, then it leads to a development of both collecting system in the kidney. The kidney actually gets mature, developed into kidney only when it gets signal from this ureteric bud. If ureteric bud doesn't develop, then whole kidney of that side will be not developed. If anyhow ureteric bud is developed, but if it has no interaction, have not developed proper interaction with this metanephrons, metanephric mesenchyma, then also the kidney will be functionless. So this ureteric bud and this metanephric mesenchyma, they come together and have interaction between it, and after that there is a formation of this mature kidney, as well as this ureteric bud helps in the formation of other part. Like ureteric bud actually form the ureter, the lower portion, and it's from the pelvis, then the major calyx, minor calyx. Normally when you see the kidney, then there is pyramid, and pyramid is opened in the minor calyx, then comes into the major calyx and as a renal pelvis. Okay, so this minor calyx, major calyx, renal pelvis and ureter, this all thing is formed by this ureteric bud, and also the collecting duct and tubules. Whereas after this portion, that is metanephrons, which is present there, metanephrons or metanephric mesenchyma or blastema, that will form the other part like glomerulus, Bowman capsule, okay, proximal convoluted tubule, loop of Henle, and distal convoluted tubule. So this glomerulus, Bowman capsule, proximal convoluted tubule, loop of Henle, and distal convoluted tubule are formed by this metanephric blastema or metanephric mesenchyma. Whereas ureteric bud will form other part, like after distal convoluted there is a collecting ducts and collecting tubules, that will form by ureteric bud, and other part that is minor calyx, major calyx, ureter, this all will form by the ureteric bud. Also that will the fate of these metanephrons, where mesonephron will degenerate. In male, it will help in the formation of the male genital organs, mainly ductus deferens and epididymis. In female, it usually get remnant and remain as Gardner duct. Okay, so in female it usually get degenerated and remain as Gardner duct. Okay, so now we know about the embryology. Embryology will be pronephron, mesonephron and metanephron. Pronephron 4 weeks degenerated, 5 weeks forms the mesonephron. At the end of 4 weeks, a mesonephron comes, which has two functions. One, it helps this metanephron, which comes in 5 to 6 weeks, for the formation of mature kidney, and also it forms the other part of this urogenital system in the kidney excretory system. You understood that point? Okay. Now there will be important question regarding this. A question can be made. Actually, question can be made about this ureteric bud and this metanephric mesenchyma. Okay. So these two things you have to remember. The condition that will, if ureteric bud is not developed, then if ureteric bud is not there, then this metanephron will also not be developed into mature one. So ureteric bud absence means the whole one-sided renal agenesis. So one-sided renal agenesis can occur due to the absence of the ureteric bud, and that comes from the mesonephron, not metanephron. That you have to remember. Okay, even if the ureteric body comes, but the interaction between this ureteric bud and metanephrons doesn't occur, then that is called the multicystic dysplastic kidney. Means functionless, that we can only become a connective tissue and cyst So that is multicystic dysplastic kidney. These two are the abnormality that can be found. Okay. Now, when we talked about this, all this thing, then there will be a one major thing that will be asked about is porter sequence. If both sides there is the problem in this ureteric bud, then there will be bilateral renal agenesis. And if a person has a bilateral renal agenesis, let me tell you one thing, that when we are in the uterus, the baby is major portion is responsible for the formation of amniotic fluid. Okay. In the first trimester, what happened, the baby skin, our skin was so porous that water and solute easily move between the skin. Later on the second trimester, our skin gets keratinized and become impermeable to this amniotic fluid and solid material. So in first trimester there was no issue, that every fluid and solid component can pass through the skin, then no problem. But when it comes to the second trimester, when keratinization of the skin occurred, then what happened, that fluid and water cannot move into the body. So what happened, now the renal system, the excretion, actually canalization of the all collecting system occurs in 8 to 10 weeks. So at 10 weeks, 8 to 10 weeks of your life, the all kidney is actually developed. Even canalization is developed. That is important thing. Okay, in 8 to 10 weeks. Before 8 to 10 weeks, some of this kidneys part can secrete urine, and there will be a transient hydronephrosis. But that will resolve after recanalization, which occurs at 8 to 10 weeks. After 10 weeks also, if the unilateral kidney or unilateral there is hydronephrosis, then this pelvic ureteric junction, ureter and pelvic ureter junction, has maximum chance of getting obstruction. So if you are finding even after 10 to 10 weeks that their kidney is there with hydronephrosis, then there may be a chance of pelvic ureteric junction obstruction, which is the most common side. That also you should have to remember and keep in mind. Okay. So I was talking about amniotic fluid. So amniotic fluid, I have told you that amniotic fluid. I have told you about that. That in first trimester of life, baby skin is permeable to the water and solute, easily pass through it. Second trimester, this skin get keratinized epithelium and becomes impermeable to the water and solute. So kidney is responsible for formation of urine and formation that will contributes into the amniotic fluid. Okay, and that amniotic fluid is again swallowed by the baby, that goes inside the body, get absorbed into the blood, again excreted through the kidney, and some of the are taken care by the mother, that goes to the umbilical vein and to the umbilical artery and vein. Okay, so they can be taken care by the mother. Now important thing is there is a balance of excretion and swallowing of amniotic fluid, and it maintains the amniotic fluid what is required for the body. The main function of amniotic fluid is prevention of baby from any abdominal, maternal abdominal trauma. It has act as a cushion between the that prevent the compression of the placenta between our umbilical cord, between the mother and the fetus. Then they provide the nutrition to the baby, and there are other functions as well. Okay, it has some antibacterial properties as well. Okay, so this amniotic fluid, if there is renal agenesis, so now baby is not secreting the urine. If it is not secreting the urine, then there is no contribution in amniotic fluid formation much. So there will be only oligohydramnios. If oligohydramnios, then there is less amniotic fluid in the uterus, then that will leads to the compression of the growing fetus against the mother, and may leads to a sequence called porter sequence. P-O-T-T-E-R, porter sequence. Okay, so this porter sequence, this is the porter sequence. It is a rare condition but can occur, and it is very severe condition. Actually, if a baby has a bilateral renal agenesis, then after birth, he usually does not survive. Okay, what are the porter sequences? Porter sequences, there will be the pulmonary hypoplasia. Actually, what happens when a baby, this is pulmonary hypoplasia. What happens when a baby is in the oligohydramnios fluid, when the maternal is having oligohydramnios and baby is there, then there will be a compression on the face. Okay, so there will be a flat nose, this low satiety, this retrogynthia, the damage in the face, the limb abnormalities, then there will be a compression of the chest. Even amniotic fluid aspiration helps in the maturation of the lung. If that is also not going to occur, then there will be the pulmonary hypoplasia. So renal genesis, pulmonary hypoplasia, this will lead to the death. Okay, so Porter sequences, consequences is, what are the, you can remember as POTTER, that is pulmonary hypoplasia, O4 oligohydramnios, that is trigger for that. Okay, T4 twisted skin, another T4 twisted face, then E4 it is extremities deformity, and R4 that is renal agenesis, bilateral renal agenesis. So this is almost incompatible with life, but it can be asked in your USMLE section. Okay. One thing you have to remember about the Porter sequence is the most common causes. I have told about the bilateral renal agenesis. There are the other causes as well, like autosomal recessive polycystic kidney disease. Okay. Then bilateral renal agenesis, I have already mentioned, renal agenesis. Then there will be chronic placental insufficiency. Placental in this, if there is a chronic. And another will be, this is urethric. If there is, if you are saying that urethra, if posterior urethric membrane is maintained, then there will be the backward pressure and urine will not flow out. Then in that situation also there will be the hydronephrosis of the both kidney and may lead to the Porter sequences. Okay, because Porter sequences is the triggered by oligohydramnios, and oligohydramnios can occur if there is a remnant, if it is the persistent of the urethral membrane. If posterior urethral membrane is processed, then no urine is passed through the urethra. If no urine is passed through the urethra, then it leads to the backward pressure, and backward pressure, so urine is not passing and unilateral. So there will be a oligohydramnios, but the more important thing is that both sides there will be the hydronephrosis. You remember one thing, that if you are having any problem in the pelvis, suppose stone, any obstruction, or in the ureter, or in the uretero and vesical junction, if anywhere there is a problem, then that will lead to the unilateral hydronephrosis. Unilateral problem is there because one side. But when it comes to the urethra or internal urethral orifice or anywhere present in the urethra, there is single blockage, but both kidney drain through it. If there is a urethral or blockage, then it will lead to the bilateral hydronephrosis. That is important. One side unilateral in the urethra, bilateral. That is important. Okay. So we have talked about this thing also. Now the remaining now what are the remaining? One is Horseshoe shaped proteins. Horseshoe shaped kidney. This horseshoe shaped kidney is what? The horseshoe shaped kidney is actually nothing. When during birth, the kidney actually is in the pelvic region and it ascends. When it ascends, if it posterior pole both kidney fuses, then it's become a horseshoe shape. When it ascends from the pelvic cavity into the abdominal cavity, then if you remember that this is the abdominal aorta, there are three branches. Okay, when you remember about the abdominal aorta, there are actually lateral branches, ventral branches, dorsal branches, and terminal branches. Means that this is the ventral branches, this is the terminal branches, this is the lateral branches. Okay, and posteriorly there will be the dorsal branches. In ventral there are three: celiac trunk, superior mesenteric artery. This is celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Okay, so when kidney tries to ascend and this point is fused, so when it tries to ascend, it will get obstructed here. in the inferior mesenteric artery. There is an artery. Artery is coming from here. Now kidney goes over. This is fused, so it get obstructed over here, and after that it can't move. It can't walk. So one question can be made from here also about this inferior mesenteric artery and relation to the Horseshoe circuit. That can be made. I was talking about the abdominal outer branch. Actually, you remember this is abdominal ventral branch is celiac trunk, superior mesenteric and inferior mesenteric artery. When you are talking about the lateral branch, this is the GPRS, that is gonadal artery, phrenic artery, renal artery, and suprarenal artery. These are lateral branches. Terminal branches are common iliac artery. Okay, this is common iliac artery branch. Lateral branch I have got, and dorsal artery is the dorsal lumbar arteries and median sacral artery. These are the branches of abdominal aorta. Why I have discussed about this? Because when you talk about the renal supply, then this is directly from the abdominal aorta. Renal artery is directly from the abdominal aorta, which is the lateral branch of abdominal aorta. Okay, through venous drainage, it goes into the inferior vena cava. Okay, so it goes into the inferior vena cava. Right sided everything drained directly into the vena cava, whereas in left side, left renal vein is long, and it also drains. In left renal vein, there is a gonadal vein, that is testicular and ovarian vein drains into it. Then there is the phrenic vein drains into it. Renal vein is itself left renal vein, and suprarenal vein also drains to it. So when you talk about the left kidney, that is the left kidney. So left kidney, left renal vein drains into the vena cava, but it has a long course, means it has a long vein, and also it has other vein drain into it, that is the gonadal vein drains into it, then phrenic vein drains into it, then renal is itself, and suprarenal drains into it. That you have to remember. And I am focusing about this, that you now know about the arterial supply, you know about the venous supply and how it drains, but you should know that this renal vein left side is larger one, and because of that, normally when we are going to use a transplant kidney, then we will take the left kidney for transplantation. Okay, so if a donor is there, we'll take the left kidney because it has a long vein, and we will take that vein, left kidney, and transplant, put it into the iliac fossa, right or left iliac, mainly right iliac fossa, and connects it with the internal iliac vein and artery with the intra-iliac artery and vein with the iliac vein. Okay, so in this way we can do the transplant, and it can be asked about that left renal vein, since it has a long course and large vein, so it can be used for the transplant. Which kidney is used for transplant? No, it is always taken the left kidney because it has a long vein and easy to put it back. But when we are going to give in the recipient, its kidney is usually in place, only the donor kidney will be placed into the right iliac fossa. The damaged kidney is in the situ. Do not do anything with that. Okay. Now comes to this renal system, glomerulus part. Okay. We know that this is composed of Bowman's capsule, glomerular capillaries. Okay. Then there are the tubules, that is proximal convoluted tubule, then loop of Henle, then distal convoluted tubule, ascending loop of Henle, distal convoluted tubule, and then collecting ducts and collecting tubule. That we'll discuss later in the physiology. Here, what is important is that when this is the Bowman's capsule has afferent arteriole and efferent arteriole. Okay, and at the afferent arteriole there is the JG cell and distal convoluted tubule also comes. In the distal convoluted tubule there is macula densa, there is JG cell in the afferent arterioles. Okay, so this is important. There will be a lot of questions regarding this portion, that's the afferent arterioles. There will be the JG cell. Okay, in the medial layer of the artery there will be the JG cell, and macula densa is actually a place in the distal convoluted tubule. So when there is low sodium, due to any reason, if low sodium is passed through the all the through the kidney and reaches low sodium at the distal conductivity, that is at the macula densa, then it sends there is a chemoreceptor. So there will be chemoreceptor at macula densa. It sends the sodium and then accordingly activate the J cell to release the renin if the sodium is low, and renin-angiotensin aldosterone mechanism is activated. We will discuss in detail. Okay. When there is low blood volume, when there is hypotension, when there is low blood volume, then in low blood volume there is a baroreceptor. This JG cell is baroreceptor. This is important, you should know about it. There is in kidney, like in carotid arch, there is chemo and baroreceptor. Same in kidney, there is chemo and baroreceptor. Chemo is that detect the sodium potassium chemicals. Okay, baroreceptor is detect the pressure. If there is low volume, then this GG cell get sense that through that baroreceptor, sense it and release the renin, and it again activate the renin-angiotensin aldosterone mechanism. So you should know about the efferent arteriole. You should know about the efferent arteriole. If efferent A is a high, E for exit. Okay, it goes into the capillaries. From the top capillaries, there is at the point of entry there is a distal convoluted tubule also come, that is known as the macula densa. In the medial layer of this efferent arteriole there is JG cell. Okay, which release this whole is juxtaglomerular apparatus, and they help in the release of renin. That is important point. Okay. Now you think also should know about one more thing is that afferent arterioles is usually dilated by prostaglandin. Okay, and efferent arteriole is usually constricted by this angiotensin 2 that present in your body. So prostaglandin is present, afferent arteriole is dilated. When afferent arteriole is dilated, then the blood comes. Okay, when blood comes, the afferent arteriole more dilated, more blood comes, more renal blood flow, more GFR, more filtration fraction is there. Okay. If efferent arteriole is constricted, then also there is more pressure, more GFR is come, but renal blood flow will decrease. Okay. So you should remember that whenever I want to focus one point here, and we will discuss in the later next about the physiology, that afferent arteriole is usually constricted by angiotensin 2 that is present in our body, but whenever we give ACI, that is angiotensin 2 inhibitor, then this will prevent this constriction and cause dilation, and there will be a vasodilation by this ACI, angiotensin converting enzyme inhibitor. If it is vasodilation, then what happens? This will increase the blood flow from here and decrease the GFR. The pressure inside this trough capillary will be decreased and more blood flow will be occur. Okay, what is the benefit of this? This benefit is when we use this ACI inhibitor, you remember when there is a kidney in a diabetic patient, if there is a development of nephropathy, microalbuminuria. Okay, so in that case, if you give ACI inhibitor, in that what will happen is efferent arterioles will get dilated, and once efferent arteriole will get dilated, now pressure here will be decreased. If pressure is decreased, then the protein will not leak. That is important. Before going into that, hope I have understood that. We will discuss later also. But the important thing is this layer. Okay, so there is basement membrane. This is the endothelium, and there is the fenestrated. So this is fenestrated. This is basement membrane. This is basement membrane. This glomerular filtration barrier. It is called glomerular filtration barrier. You see, this is your endothelium. Okay, this endothelium has fenestrated endothelium. This has endothelium but fenestrated. So the molecule can leak through it. It cannot pass more than 100 nanometers, but less than 100, this fenestrated endothelium can pass the solid. It reaches the basement membrane. This is trifoscollagen with heparan sulfate, and then there comes this fenestrated. Okay, fenestrated epithelium. So endothelium, basement membrane, and fenestrated epithelium. This epithelium is also fenestrated, okay, but here only less 50 to 60 intermolecular is not passed. So below 60, 50 to 60 is only passed through it. So if this is the filtration barrier, endothelium, basement membrane with basement membrane with type 4 collagen and heparin sulfate, and this is the podocyte. This 3-4 component makes the filtration barrier, and if there is, they are all are negatively charged. So if there are any positive charged particle are usually not transmitted, are not passed through this filtration barrier. So any plasma protein will not leak through this glomerular membrane or reach to your tubules. That is important. And if there is any damage in this barrier, then this will lead to the leakage of the protein positive charge material as well, like nephrotic syndrome. Okay, so you have understood this barrier, you have understood few parts, you have understood about the anatomy, you have understood about the blood supply, about the embryology, and about the few congenital anomalies that can be covered. Okay, so thank you. We'll discuss more in next lecture. Thank you.